decarboxylated the patient, we've managed the synchronies, we've prone position, and then it's time for the patient to leave the ICU and start weaning. And this is something that is very familiar to you all, I think, but just we'll go through a way of assessing the weaning for this patient, or whether the patient is ready for weaning, and how do we do the weaning in a more sort of structured form. So you are aware of this guideline, which I think was published in before the 1992. There is a recent one which is published just last year, and it's a combined weaning guideline from the American Thoracic Society and the American College of Chest Physicians. And I'll tell you where things are new and where things they differ. They don't differ very much, but there is one point probably is worth mentioning, but I will mention when the slide comes. And essentially you've got the journey of the patient from admission to discharge, and then you start having sort of different phases. So the first thing is the treatment of the cause that caused the acute respiratory failure. And this is the part which the guideline called pre-weaning. So these are the patients when you can start maybe titrating your inspiratory pressure, the PEEP, but you're not calling it weaning because the patient is not ready to be weaned. This is optimization. And then at some point, the patient becomes better, and you start having the suspicion this patient might be liberated from ventilation. But you don't know for sure until you do some measurement of readiness to wean, or measure some predictors. And we'll talk much more in detail in the next few slides about that. And when you've reached this phase, you plan some weaning trials. And if the weaning trials go well, and the majority do quite well, about 60 to 80% of the patients will be extubatable after the first weaning trial. So this we'll see later on are called simple weaning. But still 20 to 40% will fail, and they'll have to move on. And then we'll move on to more weaning trials, and eventually to extubation. And then here we've got another option, which is the NIV post-extubation. We'll talk a little bit later when this might be considered and when it's probably best to avoid. And obviously this is an outcome that we don't want to necessarily to achieve, but we know that a certain percentage of reintubation is part of a good clinical practice. Zero reintubation rate means you're keeping the patient far too long. 100% reintubation rate, that's not good either. So what is the right balance? I'm not sure, but the international literature is between 20 and 30%. It might be that if you've got very high-risk patients, for you 30% is far too high, but if your risk is very low, you might accept that percentage, but more about that later on. But what is most important in terms of length of stay, weaning obviously uses the majority of the time for the patient in intensive care. Okay, so this is again, a classification, and it's based on how easy it is for the patient to be weaned and liberated from mechanical ventilation. And here I'm particularly talking about patient with endotracheal tube. Later on, the last slide is going to be about a way of weaning patients with tracheostomy. Okay, so the first one is simple patients. So patients who do a spontaneous breathing trial, and they can be, at the first attempt, they pass the spontaneous breathing test, and they can be extubated. So for that, it's important that we detect when they are ready. So we need to give them the chance to prove themselves able to be extubatable. Then difficult is when you've got less than 3 failed SBT or less than 7 days. And here, these are the patients that we need to think, why are they failing? Is it about the heart? Is it about the weakness? Is it about fluid balance? We'll talk about that. Is it about because we've not addressed the underlying reason why they came into intensive care? So that's what we need to think about, reason for failure. Then there is a prolonged, which obviously you'll see more than 3 failed or more than 7 days. These are difficult patients. You need to think about MDT management, physiotherapy, rehabilitation, dietitian. So lots of MDT. And I've added this little one, which is not in the guideline, but I think to me at least it makes sense, call it long term. These are patients stay more than 21 days or require more than 21 days of mechanical ventilation for more than 6 hours a day. And this is important because as we move from simple to long term, the organizational and diagnostic complexity increases. That makes sense. But it's not all about time. It's also about outcome. So now you can see there on your left-hand side, easy weaning, difficult and prolonged. And you can see as we move from the easy to the more prolonged, the incident goes down, so they're less frequent, more rare. But clearly the prevalence of tracheostomy increases and the ICU mortality increases. And if you see the probability of death there with the days of weaning, and you remember 7 days is the cutoff that goes from the easy to the difficult, you can see a jump in adjusted probability of death when you move from one category to the next. And clearly, the simple and difficult are very similar in terms of VAP, risk, or ICU length of stay. But when you go to the prolonged, more than 7 days, more than 3 days, 3 failed SPT, that's where the real complication starts to happen. And you can see in this Kaplan-Meier curve, the survival goes down in the prolonged, whereas it's fairly similar, quite overlapping in the simple and difficult. So what I'm going to go through with you is basically 3 points. One about screening phase. So when do we know the patient is likely to breathe without assistance? And how can we predict? What kind of tests can we do? Predictive tests, so high sensitivity but low specificity. We can confirm the predicting index with something that is much more specific. So we have got the higher probability that the patient, once passes the SPT, can be safely extubated. So this is going to, again, I added this because this is what the 2017 guideline really reinforced, that we need to have a protocol. It doesn't matter what it is, they don't recommend what it is, but I'm going to suggest one anyway. But have one. And let's make sure that you always follow the same steps, because that is the things that makes most of a difference in terms of weaning outcome. But I think the one we are going to discuss together is a fairly simple and pretty obvious one, but there are some interesting points to reflect. So the first thing is, think about your clinical assessment. That makes common sense. And see whether the patient is ready to be tested for weaning. We look at some predictors. We look at the F over VT. Don't know how many people use this. Anyone uses the F over VT? RISB, quite a few over there. And the idea is that if the RISB is very high, then we need to reassess, because the probability that the patient will pass the spontaneous breathing trial are very low. But if the F over VT, we'll look a little bit more in detail later on, is low enough, so less than 100 or 1 or 5, and this is a number for patients we do on T-tube or TPs, so without spontaneous pressure support, without PEEP. The more we increase the support that we give to the patient, the more we need to adjust this number, because otherwise we'll not have the same predicted probability of success. And if we have less than 100, 105 on TPs, then we'll move on to the confirmation phase, which is an SBT. And the SBT, I think it depends on the failure risk. And by that I mean, if you have a patient, let's say 17-year-old, intubated for a simple operation, previously fit and well, the risk to that patient, if that patient fails extubation, is very low. So we can be a little bit more relaxed. And I was going to recommend either low pressure support, and this is what the recent guidelines, the 2017, recommend. Low pressure support, 5 to 7, with no PEEP, or have a TPs. And by TPs, I mean on the ventilator. You don't need to disconnect the patient from the ventilator. Most ventilators have got a continuous bias flow, so they will overcome some resistance, and you can give them 0 PEEP, 0 pressure support. And I'll show you some data later on how this more closely represents the work of breathing that this patient is going to encounter once extubated. And you can do it for 30 minutes. But let's say 70-year-old, COPD, heart failure, post-bypass. Clearly, they're not the same risk. The risk for this patient, if this patient fails extubation, are much greater. So we want to be more sure that if the patient passes the SBT, safely can be extubated. And that's why I put that in red, the T piece with flow by, and no pressure support, no PEEP. This is where the disagreement slightly is with the new guideline. They still recommend a pressure support of 5, but we will have a discussion later on and see why I prefer this, which is about some of the physiological data. And you can extend that up to 120 minutes. And the reason for that is that some patients manage to hold for 30 minutes. And then after 30 minutes, they start going down. And if you stop at 30 minutes, you might have reintubations that are quite early, within the first 2 hours. So that's something to keep in mind. This is busy just because it's intended to be busy, because there are lots of things that you make sure that we do in normal practice that a patient is ready to be extubatable. So obviously the ventilator has to be low, the hemodynamics roughly stable, there's no metabolic abnormalities, or they can be managed. So all this, I think, is common sense. But the ones that I don't think in clinical practice is very much used are these assessments. And these are the readiness testing. So one is the one we've discussed already, which is the Rapid Shallow Breath Index, or RSBI or RSBI, which is essentially a respiratory rate over tidal volume. So what do we think? If a patient has got labored breathing, how is it going to breathe? High respiratory rate or low respiratory rate? High respiratory rate. Is the tidal volume going to be high or low? So essentially this index in 1 will tell you that the patient is less than 105, again with a T piece. The tidal volume is sufficiently high and the respiratory rate is sufficiently low, that the patient is comfortable. So we go that. Now, how many people use this, the P01? This is the pressure that is measured within the first 100 milliseconds of inspiration. This is a sort of a non-volitional test, and it will give you an idea of the drive, respiratory drive. The higher this number, the higher the drive. So the patient is in dyspnea, needs some support. And any ventilator can calculate this. So that's quite easy to do. The other thing we want to know is whether the patient is strong enough. And we can do a maneuver which is, depending on the ventilator, can be called MIP, or maximum inspiratory pressure, or maximum negative inspiratory force. Now, these are just numbers I put there just as a guide. There is no set number above or below which the patient is safe to extubate. But it will give you an idea, especially when you combine them with a PO1, it will give an idea how strong the patient is. Now, how many times you ask a patient, take the maximum breath you can take, and they'll obey to you immediately, intubated? Not very often. So we need to apply a little trick. So what we need to do an expiratory hold, which is prolonged enough, and usually is recommended about 20 to 30 seconds. It might seem cruel, but I'll explain why. This is a volitional test, so the patient has to want to do it. And it is very difficult that we can make it do it unless we stop the breathing. And you can see this patient is going to take a normal breath here. So this is the maximum negative inspiratory force, might be 10. You wouldn't extubate this. You think it's too weak, too weak, too weak. And then it starts having the maximum one after 20 seconds. And here you have minus 70 or minus 60 centimeters of water. It'll give you a much better indication of the true maximum strength. So when we talk about F over VT, this is what we mean. So this is the tidal volume, and this is the frequency. You can see here the patient is disconnected from the ventilator. The frequency goes up, the tidal volume goes down, and the F over VT increases. But this is an important one. Now, this is the F over VT is essentially estimating worker breathing in a much less invasive way than an esophageal and gastric balloon. But look at the relationship between F over VT and work. It's not linear, it's exponential. So what it means is going from 100 to 150 is not just a little bit worse, it's a lot worse. So think about your targets. But RISB or FOVT is only a screening test. And the reason why it's a screening test, because if we just extubated a patient based on FOVT, we would reintubate 40% of the patients. Now, this might be acceptable or might not be acceptable. I would argue that this is a bit too high as a percentage, particularly in the general ICU. So we've been through this again, we've done that, and now we reach the SBT phase. Now I'm just going to show you some data. And I'm just going to say that the T-piece, or the flow by, depending on how you want to call it, is a much more realistic test. And realistic, I mean, is able to represent the work that the patient needs to do once extubated. So let's have a look here. This is assist control ventilation, pressure support with 0 PEEP, pressure support with PEEP, and a T-piece, so 0 PEEP, 0 pressure support. And we look at the wedge pressure, the intrinsic PEEP, and the work of breathing. So first of all, you can see that the PAOP, if we make it easy for the patient, you remember this morning, Salvatore Grasso was talking about the deep inspiratory pressures that some patients might need to take. This will affect the pulmonary artery occlusion pressure, and this will go up. The greater the effort, the greater the PAOP. The intrinsic PEEP will go up as well, and the work of breathing will go up. But then you say, okay, so why are we doing this? Wouldn't it be better if we don't make the patient stressed? We don't increase the work of breathing, the PAOP keeps at a lower level. Yes, but you have not done the right test. You have not stressed the patient to the level. This is what the patient is going to experience once extubated, and you want to make it realistic. So that is exactly what I was trying to say. You can see there the work of breathing at T-piece during the SBT and post-extubation, they're the same. So we're not giving the patient much higher work of breathing with a T-piece. They are exactly comparable. And what we gain, so there would be less elastic work of breathing, a little bit more resistive work of breathing because of the tube, but overall the work of breathing will be comparable. And at the same time, this is the same concept, T-piece up to assist control. You can see so this is a measure of work of breathing. So let me finish all the animation for you. And you can see that the assist control ventilation removes 75% of the work of breathing, whereas the T-piece will not remove any. So this is quite realistic. So I put that slide there because although I don't know how many people do cuff leak test routinely. Who doesn't do cuff leak test routinely? Okay, so the majority. Now it's very interesting because we don't do it all the time, depending on the patient, but the new guidelines recommend it. So I put it there for you. And one of the things you can do, cuff leak, will need to monitor the tidal volume, inspiratory and expiratory. Just make sure you give a good flow, enough pressure support, and then you can measure it. And some of the literature say that if we have more than 110, 130 milliliters difference between inspiratory and expiratory, once the patient is on 8 mils of predicted body weight, that is a positive cuff leak. So the patient is safe to be extubated. But I leave it there. Just if you can use it, you use it. But I don't always use it. Now, going back to the failure risk, I think you would agree that these are patients who have got higher risk of failure. So elderly, COPD, chronic comorbidities, obesity, neuromuscular disorder, particularly patients who've been ventilated for a long time or the fluid balance is positive. So these are patients where prophylactic non-invasive ventilation might be effective. And by prophylactic, I mean extubate straight on non-invasive ventilation. And if we look at the data, you can see that particularly if the patient is hypercapnic. Having a non-invasive ventilation post-extubation, they do much better. The survival is much greater. Much greater there. So there is less reintubation, and there is reduced mortality, and the reintubation again is lower. But only if the patient has got hypercapnia, not for all patients, particularly not with the one with normal CO2. So, prophylactic non-invasive ventilation. So if you look at that again, there is an interesting relationship between hypercapnia, non-invasive ventilation, and control. You can see that patients who do receive non-invasive ventilation on extubation, they have less post-extubation respiratory failure. They have less reintubation or fewer reintubation. And certainly the hospital mortality seems to be reduced. Now, this is not a huge thousands of patients sort of trial, but I think illustrate a concept. What about if the patient gets extubated and not on non-invasive ventilation and fails? What do you think we should do? This is a problem. The problem is mostly is cardiac. The majority of the patient is cardiac. Now, I put over there at the top, this is a LV, and this is the RV. And this is a Mueller maneuver, which is essentially a deep inspiration when the glottis is closed. And what it simulates is a deep negative intrathoracic pressure, which the patient might develop when he's trying to breathe and he can't breathe because either there's an obstruction of the airway or because the work of breathing is much higher. And what you can see is that during the inspiration, so the Mueller maneuver, the LV and the RV dilate. And if they dilate and the patient has got positive fluid balance or the LV function is suboptimal, they'll go into heart failure. And you can see that again from the PAOP. You can see that the harder it's too many clicks. Okay. So the harder is for the patient to breathe. Okay, you've seen the slide, and the higher is the PAOP, up to 40% increase. That means if the patient is borderline for developing heart failure, it'll be very clear during an SBT. And this is today we've seen a lot of esophageal pressure swings. So the greater the swing, the more is the patient, the greater is the effort. And you can see going from spontaneous breathing, lots of effort, to pressure support breathing, less effort, and again going back into spontaneous breathing. But how many people use esophageal pressure? How many people don't use ever? Okay, so there's someone. But we've got a very interesting device that we put in every patient, which is the CVP, and it stays in the SVC. The SVC is in the pleural space. So you can see here, this patient, when during a breathing trial, the change in CVP is very large. And you can almost imagine what would it be the esophageal pressure swing in this patient. So this was a patient with some cardiac failure, but not obvious during pressure support and PEEP. But once this patient was on 0 PEEP, I've just made the axis of time a little bit shorter. What do you think of this? I call it chain stoking. So this patient is starting having sort of a high variability in flow and volume, going from low to high, low again, and a pause and starts again. And this is one of the mechanisms of latent cardiac failure, which we have masked. And so what to do then? You start back to baseline. Is the fluid balance all right? Is the inotropic support correct? What can we do to optimize? And this is one of the trials that were in the ARDSNet. This is the FACT trial, looking at fluid conservative versus liberal. And patients who had conservative fluid, they weaned earlier. And if you pay that attention to fluid balance, particularly if you're using BNP, for example, and you drive the patient negative, this patient wean quicker, much quicker. But what about patient failing? extubation. So extubate, a few hours later, respiratory rate goes up, PaO2 goes down, CO2 starting to go up. How many people would put this patient on non-invasive ventilation? Very good. Few. Okay, how bad is it? It's not crashing, but it's not thriving. Okay. Well, maybe note of caution. This comes from a New England Journal paper. I'm sure you're all familiar with that. But essentially what this study shows, that if you use NIV as a rescue for failed extubation, I'm not talking for airway, but for respiratory failure, you have got almost a 17-18% increase in mortality in patients who receive rescue non-invasive ventilation versus the one intubated straight away. So I would put a note of caution. I wouldn't not recommend curative NIV or therapeutic NIV and think about a rapid exit towards reintubation. And there is one thing now that is becoming more popular, which is, it's lots of nomenclature, I'm sorry about that, but I'll just put it there because it's in the literature. It's called facilitative NIV. By that, what do we mean? Is patient go through all the stages up to the SBT, but they fail the SBT. Extubate anyway to non-invasive ventilation. I'm not suggesting you do that. I'm just saying it's there in the literature in the form of meta-analysis. And the jury is still out. And the BREATHE trial, which is looking at that particular question, is now concluded. The analysis has been done at the moment, and the results will be presented at the European Society of Intensive Care in Vienna in September. So if you're there, just have a look. Now, this is my last before conclusion slide, so you can relax. And I call it the slow part, because these are the patients who have failed many extubation, they are prolonged or difficult weaning, they've got a tracheostomy perhaps, and these are the ones where different strategies and methodology of weaning have been attempted, usually alternate weeks or alternate days, and essentially, how do we do it? So I would say, first of all, we need to make sure that the patient is comfortable, and the nurse at the bedside are the best people to judge that, because we want a respiratory rate that is lower, we want the patient comfortable, we want the patient gas exchange to be acceptable. And that is something that we look for for distress, clearly. If the patient is comfortable, can reduce the pressure support by 2 centimeters of water. Now, I must say, after the talk that Salvatore gave today, I don't know what the right pressure support is, but I'm assuming you don't have any way of measuring it. We're just doing it clinically, okay, for now. So the question is, we go down by 2 centimeters of water. Any evidence of fatigue, obviously go back to what you were before. But if there isn't, you can go down up to 1 or twice a day until, and obviously in this cycle, until you achieve a pressure support that is 6 centimeters of water or less. Once you get to this level, the literature, at least there is one big trial in JAMA, that shows that reducing by 1 centimeter of water a day of pressure support is just delays weaning. And at this point, they can go straight into trachea mask. Okay? By going into trachea mask, you don't set a time. You don't say half an hour, 1 hour, 6 hours. You let the patient decide how long is enough. And just before the patient is completely exhausted, you stop them and you make them comfortable again. And by that you give good amount of pressure support, good amount of PEEP. They need to recover. These are like athletes who do the sprints and then they need time to recover. And so for the rest of the 24 hours, you leave them rest. And then you try next day up until you get a tolerance of trachea mask up to 12 hours. And then usually there's a good rest overnight. That's very crucial. And you can push it to 24 hours a day. Clearly, once they've been able to tolerate for 24 hours, for 5 days, they're considered weaned. Even if they've got the tracheostomy, you can call it weaned. This is a modified protocol that comes from the JAMA paper, which has been very successful. So this were patients who considered unweanable. They went from a local hospital to a long-term weaning facility. they couldn't be weaned. They've been more than, I think, 30 days. And with this protocol, 50% were weaned within 3 days. And by that, completely liberated from mechanical ventilation. And one of the thoughts are that reducing by an arbitrary percentage of pressure support a day may lead to chronic fatigue, deflation of the lung, and therefore high work of breathing. So I think I've got only 4 points as a conclusion. I think this what comes even strongly in the last this year weaning guidelines is, doesn't matter what it is, but have a process for liberation, a protocol. Do a risk assessment with the SBT. Just be careful to the hemodynamics and the fluid balance, because they seem to be one of the most important criteria for success. And when you think about NIV, yes to prophylactic, so extubate straight into NIV. We don't know about facilitative, but come to Vienna, we'll find out a little bit. And I would say no to the therapeutic one. And with that, I thank you for your attention.